whenever you're presented with a case of acute appendicitis, you must be able to differentiate it from other cases. So today, what I want to do is to take your time. Let's take our time and break down the various differentials easily. So now let's start. Let's go. How to use the differential diagnosis of appendicitis to pick up which cases are presenting. I need someone to read this case for us, please.
A 35-year-old female presents to the emergency department with severe abdominal pain for the past 36 hours. She reports that the pain started around her belly button and has since localized to the right lower quadrant. On examination, she has a temperature of 103.5 Fahrenheit or 39.7 Celsius, and tenderness in the right lower quadrant with guarding. Her white blood cell count is 18,500 cells per microliter. Which of the following laboratory findings is suggestive of a perforated appendix? A, temperature of 99.5 Fahrenheit. B, white blood cell count of 12,000 cells per microliter. C, temperature of 103.5 Fahrenheit. And D, white blood cell count of 9,000 cells per microliter.
Doctors, please type in your answers. Is it A? Is it B? Is it C? Is it D? What are the features of perforated appendix? Okay, I think we've hit it. So the answer is C. A temperature which exceeds 39.4 is suggestive of perforated appendix, along with white cell counts more than 15,000 cells per microliter, and imaging studies which reveal fluid collection in the right lower quadrant. So options A, B, and D do not meet the criteria. Okay, so what are the features of that? Now, I want someone else to read this case for us. Then we get into the nitty-gritties of how to tell the differentials.
Which condition present with symptoms similar to acute appendicitis and should be considered if inflamed appendix is not found during abdominal exploration?
Okay, good. Please, what are the answers? Yeah, tell me.
Cecal diverticulitis, Meckel diverticulitis, C, clonic diverticulitis, D, ileal diverticulitis.
Beautiful. So, for example, you suspect that this patient has appendicitis, you are sure, and then you call the surgeon goes open up, but appendix is normal. So which condition can present similarly to acute appendicitis, but then when you go and check the appendix is normal. So if the appendix is normal, what differential diagnosis should you think about? Is it A, cecal diverticulitis, B, Meckel's diverticulum, C, clonic diverticulitis, or D, ileal diverticulitis? And I see a lot of people typing in B, B, B. I see a lot of people typing in B, B, B. Okay, so the answer is Meckel's diverticulitis. So Meckel's diverticulitis presents with symptoms which are similar to acute appendicitis and should be considered if an inflamed appendix is not found during abdominal exploration. Meckel's diverticulum is a congenital remnant of the omphalomesenteric duct, okay, and can mimic appendicitis. So one condition which can really mimic appendicitis is Meckel's diverticulitis. So now, let's jump into the various differentials. Perforated appendix versus acute appendicitis. We saw a question on it. Now let's dive deep. With a patient with perforated appendix, usually the temperature is very high, about 39.4, because the patient may be developing an abscess or peritonitis. Number two, white cell count is usually more than 15,000. And when you do imaging, perforated appendix, there's fluid collection in the right lower quadrant. Perforated appendix. So this is how you can be able to tell the difference between perforated appendix and acute appendicitis. Doctors, are we all clear? If you are clear, type yes, yes, yes. Today we are going to go to all the differentials, and how to tell them apart, because that is how you prepare for the exam. The exam is a mind game, right? Okay, good. Now, what about cecal diverticulitis? Because it was one of the questions, it was one of the options in the Meckel's diverticulous case. In cecal diverticulitis, and I've seen this interestingly in the ER, I was sure that this patient has acute appendicitis. And then we went to do the CT, and it was a cecal diverticulitis. Look for that patient from Eastern population, like India, Pakistan, you know, like patients from Asia, and they are a bit younger. And the only way to tell the difference between cecal diverticulitis and acute appendicitis is by doing an abdominal CT scan. Doctors, today, we need to be able to tell the difference. So we've learned about perforated appendix. Now we are learning about cecal diverticulitis. So if I tell you, so and so patient from Pakistan, or an immigrant from Pakistan, an immigrant from India, 32-year-old male, presents with right lower quadrant pain. On further evaluation, the appendix looks normal. What is the next possible diagnosis you think about? Think about cecal diverticulitis. Doctors, are we all on the same page? Are we all on the same page? If yes, let's move on. Yes. Good. Next differential, Meckel's diverticulum. That was what we saw in the questions there. Meckel's diverticulum is very similar to appendicitis. But the issue is that when you do an exploration, when you do a surgery, the appendix looks perfectly normal. If you get that in your board exam, the next diagnosis which should come into your mind should be that this patient may have a Meckel's diverticulum, which has become inflamed. So doctors, we've learned about Meckel's, learned about cecal, we've learned about appendiceal rupture or perforation. Please, can I move on to the next one? If yes, type yes. Dr. Khadija says, wow. Dr. Khadija, why wow? What is wrong? Why wow? What is causing you to be wowed? Can you speak to me? What is causing you to be wowed? Tell me, Dr. Khadija. Is anyone feeling wowed like Dr. Khadija as well?
Because I never know that, doctor. It's a new information for me.
Okay, good. And that is why I'm saying that, to prepare for this exam is not just enough to say, oh, acute appendicitis, I know it, right? Okay, good. Let's go on. Acute ileitis. If you see in your board exam, what are the differentials in the acute appendicitis, acute ileitis? What in the question stem should point you to acute ileitis or ileitis? Number one, when the patient presents with right lower quadrant pain plus diarrhea. Right lower quadrant pain plus diarrhea. Remember that we said that diarrhea may happen in acute appendicitis, but it is an atypical presentation. But if you have a patient with right lower quadrant pain and diarrhea, think about organisms like Yersinia, Campylobacter, Salmonella. Okay? That should point you to ileitis. Remember that Dr. Bruni, when he was teaching acute appendicitis and we got to the differentials, ileitis is one of them. Consider acute ileitis, okay? Now, I mentioned Yersinia. What is it which will really point to Yersinia? Because Campylobacter, Yersinia, and Salmonella will all present with right lower quadrant or can all present with right lower quadrant pain and diarrhea. But what in the question stem should point you to Yersinia? Number one, the patient will have abdominal pain. Number 2, the patient will have fever. Number 3, the patient will have nausea and or vomiting. And the pain is localized to the right lower quadrant along plus acute diarrhea. So acute diarrhea plus pain in the right lower quadrant with nausea, fever, should cause you to think, okay, this is ileitis. But what is the most prominent one among the ileitis? It should be Yersinia, Yersiniosis, Yersiniosis. What about if you see Crohn's disease in your options 10? Crohn's disease in the options, how will you be able to pick it up? That patient will present with fatigue, and you realize that that patient will have diarrhea, but that diarrhea, the question stem may tell you that the diarrhea has been prolonged. It's been going on for months to weeks. The patient may present with weight loss. The patient may have fever, with or without gross bleeding. So if you think this patient may have appendicitis, but the patient has, fatigue, prolonged diarrhea, weight loss, fever, and the question stem tells you that there was blood in the patient's poop, and the patient might even have had appendectomy done, and the patient is still having persistent pain, Crohn's disease should be your topmost differential. Crohn's disease should be your topmost differential. All right? How will I be able to tell the difference between tubo-ovarian abscess and appendicitis? Tubo-ovarian abscess, the patient should be female, obviously. Number 2, the patient will have abdominal pain. The patient may have fever, chills. But then one thing which will give out tubo-ovarian abscess is the patient may have vaginal discharge. So, because it could be a right tubo-ovarian abscess. So it will be right lower quadrant pain, fever, chills. But then what will separate tubo-ovarian abscess from acute appendicitis is vaginal discharge. How to tell? How to tell? You look at the question stem, you go like, boom, this is this, boom, this is that. It is if you are trained well and you're able to put all these things to bed. Okay, so I see right lower quadrant pain with vaginal discharge. I'm going to think about tubo-ovarian abscess. Right lower quadrant pain, but recurrent diarrhea, weight loss, blood in the stool. What's my diagnosis, doctors? Please tell me. What's my diagnosis? Right lower quadrant pain, weight loss,
Crohn's disease.
Crohn's. Okay.
Crohn's.
Right lower quadrant pain with diarrhea. What organisms am I thinking about?
Yersinia.
Yersinia. What else?
Yersinia.
Salmonella. Beautiful. Right lower quadrant pain with vaginal discharge. What am I thinking about?
Tubo-ovarian
Tubo-ovarian
abscess.
abscess. Beautiful.
Abscess.
I'm happy. I'm happy. So what about pelvic inflammatory disease? They also present with low abdominal pain. And then the low abdominal pain is, it may be described as the patient's pain is worse during intercourse, or jarring pain, maybe when the car is driving, the patient is experiencing a lot of pain, or low abdominal pain right after menses with fever. Physical exam, patient's temperature is high. The abdominal pain is symmetrical. Meanwhile, the abdominal pain in appendicitis is usually on the right side. Rebound tenderness on palpation, decreased bowel movement on auscultation, and the patient may have purulent endocervical discharge. Or if you do a pelvic exam, they may have acute cervical motion tenderness. If you do pelvic exam, there may be adnexal tenderness. That should start telling you this patient may have pelvic inflammatory disease. Pelvic inflammatory disease. Pelvic inflammatory disease. How are you going to differentiate between pelvic inflammatory disease from acute appendicitis? Based on clinical history and CT imaging. Next differential diagnosis. How will I be able to tell the difference between ruptured ovarian cysts and acute appendicitis? So assuming I have a question stem and I see the answer options, ruptured ovarian cysts, yesiniosis, pelvic inflammatory disease, all these ones, how will I be able to tell? Ruptured ovarian cysts, the patient will have right lower quadrant pain, and then look for that patient who says that the pain started during exercise or the pain started with sexual intercourse. So don't get the two twisted. Tubal ovarian abscess and then ruptured ovarian cyst, because what will separate the two is that with tubal ovarian abscess, the patient will have vaginal discharge. With ruptured ovarian cyst, the patient will rather have vaginal bleeding. Doctors, please, is that clear? So you realize that tubal ovarian abscess and ovarian cyst rupture may look similar, but then in a board exam, tubal ovarian abscess will present vaginal discharge. Ruptured ovarian cyst will present with vaginal bleeding. Tubal ovarian abscess may have fever.
Thank you, Dr. Bruni. You are really breaking it down and bringing out the differentials and giving us pointers on how to identify them. I never thought of it like this. Thank you.
So initially, how were you thinking about it? You just go into the exam, you see options. How will you do it? Right? Because now you can even separate ruptured ovarian cyst from tubal ovarian abscess from acute appendicitis. If I present 5 patients and I present unique differentials, so far as you are, in med cognito, you should be able to do it.
Please, doctor, it's not very clear for me between PID and tubal ovarian. Yes, doctor, please.
Sure.
Thank you.
So PID, usually all of them, both tubal ovarian abscess and PID will present with vaginal discharge, right? And don't forget that usually PID and tubal ovarian abscess, they're on a spectrum. So the patient develops PID. If it is not addressed, then it complicates to tubal ovarian abscess, right? But then in a board exam situation, look for that patient who has cervical motion tenderness. Like when you do a vaginal exam and you move the cervix, the patient has a lot of pain. But tubal ovarian abscess and pelvic inflammatory disease, they are on a spectrum. If pelvic inflammatory disease is not managed properly, it can complicate into tubal ovarian abscess. So that's a very legitimate concern that you had, right? Okay. Now, how will I be able to differentiate metal smears? Metal smears is basically like when during ovulation pain from acute appendicitis. Because one ovary is on the right, one is on the left, right? How will I be able to tell that on a board exam? Usually in metal smears, the pain is unilateral and mild. And look for that clue, which will talk about the fact that the patient is in the middle of her menstrual cycle. Menstrual cycle. Middle of the menstrual cycle. If you get a patient with middle of the menstrual cycle pain, and the pain lasts a few hours to a couple of days, no fever, pain does not come to get localized in the right lower quadrant, no malaise, nothing, that is ovulation pain, metal smears. Metal smears, I think it's a German word. What about ovarian and fallopian tube torsion? How do you differentiate that from acute appendicitis? Obviously, ovarian and fallopian tube torsion will happen in a female, right? So look for the patient with sudden, that is one word, sudden onset of low abdominal pain. That is one thing. And the pain comes in waves, comes and goes, comes and goes, comes and goes. Usually, the pain of appendicitis does not come and go. Usually, the pain of appendicitis starts diffusely around the umbilicus and then becomes localized in the right lower quadrant. But with fallopian tube torsion, the patient may be doing their thing, they don't have any malaise, nothing. And then suddenly, pain, trouble. That's ovarian and fallopian tube torsion. So look for that word, sudden. That is what is going to be the game changer for you in your board exam. Sudden. Okay. What about a patient with endometriosis? How will I be able to use like my clinical knowledge from MedCognito to separate endometriosis from acute appendicitis? With endometriosis, you realize that the patient has pain which has been ongoing chronically, chronic pelvic pain. And this pain will be described as getting worse during menses. And the patient may have dysmenorrhea, deep dyspareunia during intercourse, cyclical bowel and bladder symptoms, and abnormal menstrual bleeding. And you may even be told that this patient has infertility. Usually, in endometriosis, the exam is normal, unless maybe you do a vaginal exam and you palpate the posterior fornix and the patient may have some tenderness. But most of the time, endometriosis physical exam is normal. Now, let's talk about another very important differential, ovarian hyperstimulation syndrome, so that when you see it in your board, you don't miss it. Ovarian hyperstimulation syndrome. How do you differentiate that from acute appendicitis? The patient will present with bloating. Of course, acute appendicitis may also have nausea, vomiting, then bloating and diarrhea, and the patient will be lethargic. And start looking at that patient who presents with bloating, nausea, vomiting, diarrhea, lethargy, and also has shortness of breath and rapid weight gain. As soon as you start seeing those clues, start thinking about ovarian hyperstimulation syndrome. Now, what if the ovarian hyperstimulation syndrome is so bad? You realize that if you do ultrasound, you will see large ovaries. You may see ascites. You may even see pleural effusion. So now you start seeing things like pleural effusion, pericardial effusion, abnormalities in the electrolytes, like hyponatremia, like hyperkalemia. So in ovarian hyperstimulation, sodium is low, potassium is high. So if you see that, if you see a patient who is developed bloating, some abdominal pain, weight loss, ascites, pleural effusion, and I ask you, what abnormalities on electrolytes are you expecting? Please don't forget this ever. Sodium will be low, potassium will be high. The patient may be in hypovolemia, and you realize that the patient's blood has become thick, and the patient can even develop disseminated intravascular coagulation. Doctors, as soon as you see any of these cluster of symptoms, it is nothing but ovarian hyperstimulation. So you see, all these differentials we are learning, there's a way you can tear them apart. Okay, so how will I differentiate ectopic pregnancy from acute appendicitis? In ectopic pregnancy as well, look for that patient who is a female, look for normal vaginal bleeding, look for positive pregnancy test, and look for that clue which will say that, look, we did the ultrasound, and the ultrasound did not show any pregnancy in the uterus. That is it. Then you're thinking about ectopic pregnancy. So patient has missed her cycle, pregnancy test is positive, ultrasound did not demonstrate that there is a fetus in the uterus. That is ectopic pregnancy. Don't look left, don't look right. What about endometritis? Don't confuse endometritis from endometriosis. Endometritis versus acute appendicitis. What in the question stem should point me to start thinking, this is endometritis? In endometritis, look for that patient who recently delivered a baby, or look for that patient who recently had an invasive uterine procedure like hysterosalpingogram, like dilatation and curettage. Look for that patient who recently delivered a baby, or look for that patient who recently had maybe a therapeutic abortion, right? And then they present with fever, uterine tenderness, foul uterine discharge, and elevated white cell count. As soon as you see this, that patient has acute endometritis, not endometriosis, endometritis, inflammation of the uterine lining. What about renal colic? So you see, we are using appendicitis and we are learning all these diagnoses as well. So how will I be able to differentiate renal colic from acute appendicitis? Renal colic as well, the pain is usually in the flank and it's radiating towards the groin. The pain comes and goes, and it is in paroxysms. All right, good. What about testicular torsion? Testicular torsion, look for testicular torsion as a differential in a male, of course. Number 2, in neonates and postpubertal boys. It can, even though it can happen at any age, look for a patient with severe testicular pain. Doctors, as soon as you see that, pick the phone, call a urologist. Hey, Dr. Zoe, the urologist on call, please, I have this patient, 14-year-old male, severe testicular pain. He does not even want me to examine it. He's in so much pain. It started suddenly. I think this patient has testicular torsion. Please, this patient needs to be seen as soon as possible because testicular torsion is a urologic emergency. What about epididymitis? Epididymitis, the patient may be sexually active or not. In those who are not sexually active, you realize that they have some anatomical variation in their urologic system. All right? But then those who are sexually active, sexually active male, they may have described, heavy physical exertion, or they might have hurt their balls when they were riding a bike or a motorbike and then they landed on the bar. Now, what are the physical exam features of epididymitis? There's induration and swelling involving the epididymis, exquisite tenderness of the testis, testicular swelling, scrotal wall erythema, and reactive hydrocele. Epididymitis. Sexually active, non-sexually active. And then you also have to learn testicular appendix torsion versus appendicitis. Testicular appendix torsion, look for that male patient who is between 7 years to 14 years. And how do I remember those numbers? Don't forget that 14 is a double of 7, right? 7 years and 14 years. They have scrotal pain. Usually, testicular appendix torsion is not common in adults. So that patient between 7 years and 14 years.